Okay, so we've been talking with the students before this broadcast began. My name is Bill Schecter. I'm the former chief of surgery at San Francisco General Hospital, a job that I did for 16 years. I'm still an active surgeon at San Francisco General Hospital. I also work at teach surgery at the Muhimbili National Hospital in Dar es Salaam, Tanzania. And I also have had a relationship with the Israeli Defense Forces as an instructor and surgeon for more than a quarter of a century. And I have been assigned the task of talking about tales from the trauma room. But we were just talking before we went on air about stress on the job and dealing with medical error. And I admitted that I not successfully solved that problem even after 42 years of working and of work. But just to say that you have to, as I mentioned before to the students who are in the room, the key is to do the very best you can when things don't work out, to be completely honest, transparent, look at it, analyze it, learn the lesson, and you have to move on to the next case. Sometimes I'm in the shower and I see faces coming out of the steam or things that, from sometimes decades ago where I wish I would have made a different decision, had a different outcome. And that's just, I think that comes with the work. Personally, I wouldn't want to have a surgeon that didn't have some of those feelings. On the other hand, the person can't be paralyzed by what happened, has to learn the lesson and move on. So I thought that, I think that we should continue this kind of interaction. So if you have questions, feel free to interrupt me and we'll see where the conversation goes. But I thought that I would start out with a story to illustrate the immediacy of this kind of work, the challenges, the difficult decisions that you have to make based on inadequate data, and how rewarding it is, challenging it is, but also to talk a little bit about the burden, the clinical burden of doing this type of work. So I found myself during the Second Lebanon War in the city of Safed, which is a town which first came to fame in the Middle Ages, which is about 10 clicks from the Lebanese border by helicopter, and it's about 25 or 30 clicks by air from the Syrian border. And a young man, 29, was driving home to his village in northern Israel when a missile landed and a shrapnel ripped through the door and caused a sucking wound to his left chest. His mother was a trained nurse. She went out and initiated resuscitation. The paramedics arrived, took him very quickly, he was in very bad shape, took him to an aid station. They quickly realized that he needed more sophisticated care, put him on a military helicopter, and he was going to Haifa to the Rambam Medical Center, which is a huge tertiary care medical center right on the coast of the Mediterranean, when the military physician in the helicopter realized that the patient was deteriorating rapidly, and he made the courageous decision to land at our hospital, which was about 15 minutes closer by air, and 15 minutes is not a lot of time, but and he, in a sense, violated protocol to a certain extent, landed, and we received the patient in the hospital with no blood pressure, covered with vomitus, and with agonal respirations. In the fog of war, his death was reported on the radio, and his parents were told that he had passed away. Meanwhile, in the operating room, I opened his chest, which was not a very difficult job since the shrapnel had done it for me, thinking that the main problem was in the chest. But to my surprise, there was almost no blood in the chest. There was a blast injury to the lung, a couple of holes, and there was a hole in his left hemidiaphragm. The diaphragm is a thin muscle that separates the chest from the abdomen. So I then proceeded to open his abdomen, and I found his entire blood volume in his belly, and his spleen, which is an organ sitting up here in the upper part of the abdomen, was pulverized, and a big hole was torn in his transverse colon. So we took out the spleen, stopped the bleeding, exteriorized the colon, made a colostomy, and we did something that's called damage control. Damage control is a term that is a nautical term from the Navy and the Coast Guard, where if you have a hole in the ship, rather than to keep trying to fix the hole and let water keep coming into the ship, you seal off part of the ship. In other words, stop by closing watertight compartments in order to save the rest of the ship. So in other words, instead of trying to do a complete repair, you just seal off part of the ship so the ship stays afloat, gets towed into port, and then you do the ultimate repair later on. So we have adopted that concept in surgery because when you're so sick as this patient was and was in shock, the tissues of the body were bathed in acid because of poor perfusion of the tissues. And we know now, we've realized in the last 20 years, that to resuscitate a patient is a 24 to 36 hour experience. You just don't get, the fact that the blood pressure comes to normal doesn't mean that the patient is resuscitated. So we have learned that rather than try to fix everything, we just stop the bleeding, close the holes, and then go to the ICU, warm the patient up, resuscitate them, and then return. And that's what we did. And the patient, over a period of a week to 10 days after on a ventilator, being terribly sick, was shipped to another hospital, to a friend of mine in the center of the country, so that we could free up ICU beds to take expected more incoming casualties. And of course, when I was interacting with the family told me, which was very interesting, that I was the messenger from God, because they had been told their son was dead, and now their son was alive. We didn't know at the time whether he was going to remain alive. And so my point is that medicine in general, and surgery in particular, is at the interface between science and myth, between rationality and myth, religion, whatever you want to call it. We use the principles of science, which in fact is amoral. You observe something, you make a hypothesis, you test the hypothesis experimentally, and the hypothesis is either correct or it's not correct. There's no value associated with it. But in the rest of our lives, we make human decisions based on values that we decide upon, that it is good to help other people. It is good not to stand by somebody who's bleeding without trying to stop the bleeding. These are 2 commandments, by the way, from Leviticus. But these are decisions that we make as human beings. And so when in medicine in general, and surgery in particular, and trauma surgery in particular, we're working right at the intersect of values, myth, religion, and science. So the question is, I suppose all of you are here because you're interested in surgery, maybe, interested in trauma, and how did I happen to be there? What was my path to get there, to be at this place in northern Israel in the middle of a war with incoming missiles, and to be able to help this patient who really had one foot in the grave and another on a banana peel, and eventually succeed with successful outcome. By the way, I saw him about 2.5 months ago in Salford. He came to visit me when he heard I was back in the hospital, and he's doing fine. So when I was in college, I was a political science major, and I was interested in philosophy, political science, but I also wanted to do something that helped people, and I was thinking about government. I was thinking about a military career, an intelligence career, and my time in college was the mid to late 60s, and it was a time of tremendous turmoil in the United States, if you remember. Martin Luther King had been assassinated, Robert Kennedy had been assassinated, the Vietnam War was raging, and rightly or wrongly, I decided that my path would be, in terms of making a contribution, would be better served through medicine, probably influenced by my mom, who was at Normandy Beach as a combat surgical nurse. And I think that she influenced my path. And then I went to medical school after graduating in political science. And I think the point I'm making is, you, as an undergraduate, you should study what interests you and pursue your passion. But you have to do it right, and you have to do well, otherwise you're not going to get accepted to medical school. But study what interests you. I don't think it really matters what you study. I think Harold Varmus, who's a Nobel laureate, one of the people who who discovered oncogenes, he was an undergraduate a literature major. So just study your passion, and that doesn't mean that that's necessarily that's what you're going to do professionally during life. Now, I was interested in the situation. Well, let me just tell you another thing that happened. When I was a second-year medical student, my father had a cardiac arrest, and he was successfully resuscitated in a coronary care unit. So I became very interested in resuscitation. And he lived for 7 more years. He got to see me graduate from medical school. He got to see me get married. He held my firstborn in his arms, the guy who's now a surgeon. And it was a tremendous gift for our family and for him. So I got very interested in resuscitation. And I got interested in the situation where somebody is walking down the street and suddenly, unexpectedly, like that, is stripped of all the props of civilization. And they're staring eyeball to eyeball at their own mortality. Whereas 2 minutes before, they were in a totally different situation. And I thought to myself, that's a very interesting situation. And I decided that I would spend my life trying to help people in that situation, try to get them off the hook. And that's why I personally decided to become a surgeon, and also to spend a good portion of my career, not all of my career, because I'm a general surgeon. I do everything, but a large part of my work is emergency general surgery and trauma. Anybody want to say anything or ask any questions about this part of the story before we continue? Yes, sir.
How do you typically calm your patients down when they're in that situation?
Okay, so the question is, how do I calm my patients down? And the answer is, it depends on the situation, and it depends on the patient. And in order to be a good doctor and a good surgeon, you have to understand the culture of the patient with whom you're interacting. And for example, where I work at San Francisco General Hospital, we have a very, very diverse patient population. There's something like 30, 35 languages spoken in the hospital. I don't speak all of those languages. However, I do speak 5 languages. And I think it's in order to understand different cultures, you have to be somewhat conversant with their languages, because the way people think is to a certain extent influenced by the structure of their language. It also depends on whether they're a religious person or not. It depends on what the religion is. For example, I remember on several occasions religious Catholics who were about to undergo difficult operations or be in the trauma room asked if I was a priest. Several people have asked me that, maybe because I happen to be Jewish, but maybe because I'm bald and have white hair, it might look like a priest. I don't know. And I say, well, and I recite with them the Lord's Prayer, which I learned from a movie, watching James Cagney recite it. But that's, but the point is, I try to respond to what the patient needs at the particular time. And I remember 2 Palestinian teenagers were roaming around the hospital very, very angry because their cousin, who was working in a grocery store, had been shot in the head with during a robbery attempt. And he was not doing well and was not going to do well. And I just sat down with them, and one word in Arabic, inshallah, it is the will of Allah, took care of the problem. It didn't save the patient, but in other words, I explained the situation in a culturally relevant text that was meaningful to them. Okay? So the answer is, I try to understand that. Am I always successful? No. I'll tell you a mistake that I made culturally. There was an elderly man who was admitted to the hospital with what was thought to be an infection in his toe. And in fact, he had a big tumor on his toe. It was a malignant melanoma, which had metastasized. It had spread all over the body. And he was nearing the end of his life. And he had 2 grown daughters, lovely ladies, with their husbands. And they asked me what caused this. And I looked at them and I made a mistake. I made a cultural mistake. I said to them, you know, I don't really know what caused this. And we don't know what causes it. If I actually knew what caused cancer, I would probably get the Nobel Prize. In other words, I wanted to, and I thought that I was saying, we're at this particular moment in time, we're ignorant. We don't really know. But they interpreted my remarks as me making a joke and making light of the fact that their father had, and I was totally unaware of this till 2 days later when one of the husbands told me, and I sat down with them, but the damage, I apologized, but the damage had been done. In other words, instead of trying to relieve stress from the family, which was my job, I made it worse. So I'm not standing up here like I have all the answers, because, and I'm still a working surgeon, and when you're working, no matter how much experience you have, you are going to make mistakes. So that was a mistake that I made, and that was a remark that in retrospect I wish I had not made, and I would like to take it back, but I'm sure they're still thinking about that remark, and it's probably 20 years later. Any other questions? Yes, ma'am.
A lot of people believe that doing surgery kind of eliminates patient interaction to a very large extent, and so a lot of people steer clear of that because they want that patient interaction. But what you seem to be describing is that there is in fact a large part of that associated with surgery. So do you think that it's correct to assume that surgery eliminates patient interaction, or do you think that's very incorrect?
I think it totally depends on the surgeon, and it totally depends on the doctor. I know some non-surgeons who have very little patient interaction, even though they're sitting with them. It depends on the remember, when you're a student and when you're a resident, it's like being a student pilot. You know, you're checking this out, you're checking that out, and you're flying by the manual. On the other hand, if you're in combat and you're flying by the manual, you're going to be blown out of the sky. You understand what I'm saying? You have to achieve oneness with it. So, and eventually, when you master what you're doing, your work becomes an extension of who you are. So there are people who like to interact with others, and there are people who don't particularly like to do it. There are people that are more skilled at it, and there are people who are less skilled at it. And I'm not claiming that I'm the most skilled person at it, but so the answer is I don't agree with that at all. Anybody, any other questions? Somebody else had their hand up? Yes, ma'am.
So in a previous case, you mentioned that you were, there was the patient with the chest cavity that had the shrapnel, and that was the first place you addressed, but it ended up being an issue with the spleen. What's the time frame to kind of ensure success before it takes a turn?
Okay, that's a great question, and the answer is it depends what the injury is. And in trauma care, we used to talk about the golden hour. That if somebody arrives in the hospital alive, you had about 6. Now, if they come with airway obstruction and they're not breathing and they're alive, you got about 4 minutes to solve the problem. All right? On the other hand, if they come with bleeding, it depends what the rate of hemorrhage is. If they've got a hole in the aorta, which is the main pipe coming out of the heart, and they're alive when they come in, you have a very short period of time because the rate of hemorrhage is great. On the other hand, if they have a hole in a smaller artery or a vein and the pressure has dropped and there's a clot on there, you may have more time. But we say that we like to make a diagnosis of all injuries that are life-threatening and solve those problems within 60 minutes. Now that concept has, the rigidity of that concept is no longer accepted. It's a little more fluid, but still the basic principle is the same. And I think this is what surgery is about. When people ask me what surgery is about, it's really not about cutting and sewing. It's about identifying a problem and solving the problem. We want to take the shortest line between identification A and solution B. That characterizes the surgical personality. Now sometimes it depends what the situation is. If you're bleeding to death, that's a great way to deal with a problem. On the other hand, if you have a complex social situation and you approach it like that, you can be like a bull in a china shop and create a lot of political problems. So you also have to understand the situation that you're dealing with. But in general, the other point to add is that when you're in a clinical situation, or when you're in life for that matter, you're being bombarded from 360 degrees by all sorts of information. Most of that information has absolutely nothing to do with the real issue. And the skillful surgeon knows how to filter out the noise and focus on the signal, because the signal to noise ratio is extremely low. And you'll have all sorts of people trying to sort of be a roadblock between, once the problem is identified, to solving the problem. It's akin to a football player with a football. The patient is the football. The football has to get over the goal line. There are all sorts of people blocking the road, and you have to do a sort of run around and avoid all the blockers in order to get the football over the goal line. That's basically what we as surgeons are trying to do. We're trying to solve the patient's problem as quickly and as expeditiously as possible. Any other questions? Sir?
Do you use PAs in your practice, and if so, can you speak briefly to their role?
Yes, we do use PAs. As many of you may have heard, there's been a dramatic change in medical education with work hours restrictions. And there were also a lot of complaints before the changes were made on the part of trainees that they were doing a lot of service, in quotation marks, type activities, which were not educational. And there were also concerns from the body politic about decisions that trainees who were tired were making that may not have been the best decisions. So for a variety of reasons, the work hours were cut back on the part of trainees. And so most academic practices, and I'm involved in an academic practice, have relied on physician's assistants to do a lot of the work that were previously done by surgical trainees. I don't have experience in private practice. My friends who are in private practice tell me that physician's assistants are an integral part of many of their practices. And so this is a group of professionals who are highly skilled, highly intelligent, and I don't think we could do our work now as efficiently or as well as we do it without them. I don't know if that answers your question.
No, thank you very much for your insight.
Any other questions? All right, well, let's go on then. So let me tell you a little bit about surgical training. Let's see, how are we doing on time here? I trained as I started as a rotating intern at San Francisco General Hospital after going to medical school in New York. And I did rotations on internal medicine. I traded off my obstetrics rotations and my psychiatry rotations for more trauma because I was interested in trauma. And I did pediatrics and I did emergency room work. So I had a very broad internship experience. And nowadays, almost no one does an internship like that anymore. You do a straight medicine, straight surgery, or if you're going into anesthesia, you do some medicine and surgery. But it's not as broad an experience. The level of responsibility now is less because for the reasons that I previously outlined, which I think has advantages and major disadvantages. But at the time, and now we're talking about 1972, I did a rotating internship. Then I went and I did 2 years of anesthesia training at the Massachusetts General Hospital. At that time, anesthesia residency was only 2 years. I did a full residency in anesthesia. And then I came back to California, to the University of California at San Francisco, and did a residency in surgery. Then I did a fellowship in hand surgery to learn the principles of reconstructive surgery. And then I worked for 2 years at San Francisco General Hospital. But then my wife and I, my wife is an infectious disease specialist, we were interested in the developing world. So she was the chief of medicine and I was the chief of surgery at a hospital in Tutuila in American Samoa for 2 years, where we did everything. I did neurosurgery, orthopedics, did a lot of hand surgery, which I was trained in, but I also did a lot of things that I did not have a lot of training in. And I brought a huge library with me because if I didn't do it, nobody would do it, because there wasn't anybody else to do it. And my wife did all the liver biopsies, she did all the dialysis, she did all the tuberculosis and leprosy treatment. So we both had very good experiences. And then we went to South Africa. And maybe you'd be interested. At that time, it was the time of apartheid. So as opposed to faculty meetings that I attend now, the issues that we would discuss was how do you run an integrated residency training program in a segregated society? How are you going to teach medical students who are going on strike every 6 weeks fighting for their political freedom? How are they going to learn medicine when they're in that situation? How can we provide quality of care to everyone regardless of their ethnicity in a society which is unequal? And these questions actually have some relevance to our own society, although we don't like to say it, and it's certainly not to the same degree. But these were fascinating questions. And I was in a hospital that was a referral center for 20 million people. And although educationally this concept is challenged, and I think rightly so, I still think, though, that high volume of experience early in your career is critical to mastering a subject, whatever it is. You know, talk about the 10,000 hours or whatever it is. But I was fortunate enough early in my career to get exposed to a high volume of high-risk cases. And I think that was very helpful for me as a basis of experience as my career went on. Any questions about my overseas experience? Okay, well, let's talk about trauma now, and some more stories. And well, this is an interesting story which may have meaning for you. There was a young computer systems engineer that came to San Francisco in order to install a computer system. And he was out at 3 o'clock in the morning at a bar. And there was some conflict that occurred between this gentleman, who was a great guy, and somebody else. And as he left the bar, he was stabbed in the back. And it was July, and our research residents had just come out of the lab, and though they were away from the clinical arena for a couple of years doing research. But this particular guy had natural ability as a clinician. And he saw this patient in the emergency room. This was about 2 or 3 weeks after he came out of the lab, and said, this guy needs to be in the operating room right now. It was the right decision. He unlocked the gurney, calls me up, and I said, okay, I'll meet you in the operating room. Got there, I walked in the operating room. We had a lot of, because he was in shock, all his veins were collapsed. We had a little difficulty getting IVs in him. And as we were trying to get the IVs in him, basically, he died. But we were in the operating room. He was stabbed in the left chest. And we opened his left chest, and his entire blood volume was his left chest. So I could see the heart. Now, a lot of times this is because of a hole in the heart. And actually, if you can get the blood evacuated from the sac around the heart, put a stitch in the hole, and it happens right in front of you, there's a pretty good success rate in restarting the heart and having an alive patient. But this problem was not in the heart. So we're there, and we're thinking, well, this is either in the aorta, which is the big pipe coming out of the heart, or it's in the lung. And I said, well, my chance with a guy flat on his back of solving an aorta problem is very, very small with no heartbeat. So what I'm going to do is I'm going to assume he's bleeding from the lung. Did I know that? No. You have to make an assumption. And I put my hands around the hilum, the part of the blood vessels and the bronchus going into the lung, and put a non-crushing clamp on it, basically to exclude the left lung. And the bleeding stopped. Now this is all I know. And so now we're squeezing the heart. And the anesthesiologists are giving all sorts of medications trying to restart the heart. We're pouring warm saline on top of the heart, trying to warm it up. And I'm there for 25, 30, 35 minutes with no cardiac action. So the question is, how long should we keep going? And the answer is, nobody knows. So I start having a conversation with the anesthesiologist about various types of medications they were giving. And I asked them to give another type of medication, which was controversial. Well, I'm squeezing there, and the guy in the middle of the night starts quoting me papers from various places saying that this doesn't work. And I said, and it's like 3:30 or 4 o'clock in the morning. I said, just do me a personal favor. Just it can't get any worse than this situation. So anyway, he gave it, and whether that medicine had anything to do with it or not, I have absolutely no clue. But the heart started beating. So there we are now trying to warm the patient up, because I got this clamp on the lung. And then we waited for his heart to stabilize. We waited about 10 or 15 minutes, and the heart was doing okay. So then I released the clamp, and there was this massive hemorrhage coming out, but luckily it was confined to the lower portion of the lung, not the whole lung. So I was able to do a left lower lobectomy, take the lower lobe out, and the patient survived. Now, did that have anything to do with me? I actually doubt it. I think that patient was extremely fortunate, and I think we have to go back to the original story that I told you, that the surgeon is the messenger of God, and I think that was a very, very lucky thing, both for the patient and for me. And he survived, but not only did he survive, now remember, this guy is getting hand compression of his heart for 45 minutes, but he went back to work as a computer systems engineer with his intellect intact, and then would send me postcards from various places in the world where his company had sent him to install these computer systems. So that's an example of a miracle, and it gives you an example of the type of immediacy and thrill that this kind of work can give to you. Now, the greatest thing there's no greater thing than surgery when it works. Unfortunately, there's no greater hell when it doesn't work, when it doesn't work out as you planned. Any comments or questions based on what I've told you so far? Okay, so we've got about 7 more minutes. So let's talk a little bit. Let's say you are interested in medicine, let's say, just because I'm a surgeon, and you go to medical school, and then you're trying to decide a career, and you're balancing lifestyle versus commitment to your work, the ability to deal with stress, as that gentleman asked me previously. How do you put all these things together, and how do you decide whether you want to have a life as a surgeon and as a trauma surgeon? And the answer is, I can't tell you, because the decision is going to be different for each individual. But what attracted me to surgery was the immediacy, the problem solution attitude of the most of the people that I had interacted with in surgery. I enjoyed the technical challenge, and it was a challenge for me. Now, there are some people in the room who have natural ability, technically, okay? I have to admit that I do not have natural ability, technically. My poor wife had a broken garage door window for 2 years before her father finally came and fixed it for her. Okay, does that tell you something? However, when I decided that I wanted to be a surgeon, I knew that I had to solve that problem. And it took me a decade of total concentration to solve the technical issues. And I was always concerned about competency. Because when you're doing the difference between surgery and many other fields in medicine is, unfortunately, we hurt the patient in order to help them. When we're deciding to do an operation, we're balancing the harm that we always do by intervening with the good that's going to result as a result of the effort. Now, generally, being a coward, I like the scales to be balanced like this. I like the risk to be so low and the good to be so great that it's a no-brainer. It's not always that way, but whenever the scales start tipping, and particularly when the scales are even, when you're doing a high-risk procedure and you're not totally sure whether this is going to help or not, that's when you get into trouble. And so this is a balance that those of you who choose to do this kind of work will be making for the rest of your life. So these are the things that attracted me about it, and it also, the other thing that attracted me about it is that we were dealing with reality, that life hangs by a thin thread. None of us in the room think about that all the time or even realize it when we're going about our daily life, and appropriately so. Otherwise, we would be paralyzed. But that's actually, so what attracted me about this type of work is that I was dealing with people at critical moments in their life that are facing real issues. I found that compelling and fascinating, and that's why I decided to do it. We talked about some of the stresses and particularly dealing with medical error at the beginning before we went online. And if anybody has any more to say about that or any other things that they want to add right now, I'll open it up to you. Well, let's look in order. How many people are interested in going to medical school here? How many people are interested in going to nursing school? How about paramedics? EMTs? What are you interested in, sir?
I'm a current EMT. I've been one for 7 years, and I'm interested in becoming a physician's assistant.
Okay.
I love trauma. I'm almost 30 years old. I can't start a career at 45.
Well, I think that is a mature. I think that's a mature statement. So that now there are a lot of older students that are now being accepted to medical school, people in your age group, but I think I think every older student has to make that decision for themselves, and it's not right for all older students, and it may not be right for many older students. I went to medical school when I was 20 years old, so I grew up with it, and I know nothing else. So I'm probably not the best person to advise somebody at a different point in their life how to make the decision, because I have no experience with it. Okay, Let's see, what time are we doing now? We are right on time. So I hope that this 45 minutes that we spent together gave you some food for thought. And I don't know what you were expecting when you came, but I hope you got something out of it. Thanks very much for your attention.